Hey, thank you for clicking on the link. Congratulations. This is your first step towards your success on the USMLE exam. I am super excited to meet you. My name is Dr. Adesina. I'm the founder of Smash USMLE Review Program. Like, if this is the first time you're visiting this page, I have some great news for you. Do you have test anxiety? Are you struggling to study for the USMLE? Are you looking for a live online program for someone to be able to walk you through the steps and teach you the medical content that you're lacking? Are you having a lot of depression and feel like you cannot get through this exam? Listen, I don't want you to worry about anything because I'm here to literally hold your hand so we can crush this exam together. You have absolutely nothing to worry about because I'm going to help you eliminate every excuse in the book, motivate you, and get you through this board exam because I know you're going to be an awesome doctor someday. Now listen, let me introduce you to this online course and what you're going to be getting and why this is the most important live online course that you're going to be attending. Now let me tell you a little about the program. This is a live online USMLE review course that's going to be using an integrated case format to teach you all the concepts that you've been learning in first aid or even master the boards or other review books that you've been reading about. Okay, every week we shall be going over different modules and I'm going to be live online where you get to meet me one-on-one, where we're going to be going through cases together and why this is important and why you need to know this for the board exam. These are select topics that are the most important selected high yield content that you must master before you take your USMLE. Now, this does not cover everything you need to know for the board exam. Absolutely not. I have that as part of my self-paced online program that you can register for on smashusmle.com. But this particular review is just for us to focus on high yield cases that we're going to be running together that will augment and supplement your study. So let's look at the review. You're probably wondering, who is this guy? Well, my name is Dr. Adeleke Adesina. I'm a board certified emergency medicine physician. I've been teaching USMLE prep for the last 11 years and I'm the founder of Smash USMLE Reviews. I've received multiple awards, including the Gold Humanism Honor Awards. I've been published on kevinmd.com. We have published multiple articles for physicians. I've also been an author of the book, How to Prepare for the Medical Board, Secret for Success on the USMLE Step 1 and COMLEX Level 1. It has about 4 stars on Amazon. You can check it out. Also, I've also been a co-author of the OMT review book, which is the #1 osteopathic review book for the COMLEX boards. And I'm also a YouTuber. I'm a dean of mentoring at diversemedicine.org. And also I'm a doctorpreneur, I'm a husband, and I'm a father, and I also have 2 children. Listen, all this stuff doesn't matter because this review course is actually all about you. I believe I'm actually here to be a mentor, a coach, to be able to help you take your board study to the next level. Who is this board review for? Well, this board review course is literally for you. If you're a U.S. medical student studying for the USMLE Step 1 or Step 2 CK, or you're an IMG who came from your country, came to America, and you try to achieve the American dream so you can get through Step 1, Step 2, and Step 3 exam, and you need help getting through it, I am here for you. Also, if you're a student who's already studying for the USMLE and you say, listen, I need an online review course where we can meet somebody one-on-one because I'm tired of going to online review courses that doesn't matter and they're kind of confusing me, and I need somebody who can guide me through the process and supplement my studying with a live online course that I can use to augment my studying, then this course is for you. Now, if you failed the USMLE before or you're taking it a second time, also this review course is for you because it's really gonna take your board studying to the next level. So listen, I can't wait to help you guys and I don't want you to worry about anything. Now, if you need to discuss your situation and you register for my online course, I want you to call me. Call the number 856-258-0572. That's my personal cell phone. If you call me and it goes straight to voicemail, listen, I want you to leave me a message and tell me who you are and what you need help with, and I will literally call you back within the next 24 hours so I can basically help you and you tell me what the problem is and we're gonna crush this exam together. Now, you can also reach me by email. This is my personal email, dradesina@ftplectures.com, and I'm willing to more than happy to talk to you so we can get you to the next level. Now, if you register for this webinar, which is going to be a live online course, listen, it's going to be super awesome. I got some awesome gifts for you. You're going to get tons of bonuses just by signing up, becoming part of my group. Okay, I'm going to be giving you my insider secrets to study for the USMLE ebook that shows you how to score a 260 on the exam. You're also going to be getting another free ebook on my USMLE exam day rituals that tells you exactly how to prepare for the exam day, what to avoid, mistakes not to do, and how to easily relieve your anxiety while studying for the board exam. Also, every time you register for any of my live review course, you're going to get the instant replay and instant access to the video lectures immediately after we finish the live class, so you can access this unlimited amount of time for your own review. Also, you're gonna get a more detailed notes than the PowerPoint slide that we go through. I'm gonna give you the outline for the review course, and not only that, you're gonna get a full probably 50, 60, 100 pages of notes that actually cover all the stuff in that section. So if we go through cardiology, you're gonna be seeing all the topics that's actually tested on cardiology for step 1, and it matches your first aid. Think about it like this. It's like first aid on steroids. That's what my notes looks like. Thousands of students have used these notes and they've crushed this exam. Now, have you ever felt this way? You've been struggling to stay afloat and you feel like you're studying all day, yet it feels like you're forgetting what you're learning. Or you have so many USMLE review books, you're so confused, you don't even know which one is the right resource for you, and you just end up dumping one book from another, jumping from one resource to another, and you're getting undesirable results, which is making you feel frustrated and discouraged. Have you been reading first aid and it makes absolutely no sense? Hey, listen, I've been there myself. I've read that book a couple of times the first time I picked it up. It makes absolutely no sense. And that's the problem. A lot of people have been told, pick up first aid, read it once or twice, and you're gonna do well on the board. Bad advice. Well, how about this? Have you used UWorld, Pathoma, Kaplan, other review courses, DIT, and you failed the USMLE exam? Well, sometimes people tell me, hey, listen, I see and hear other people taking these board exams and they're doing really well and I don't know what they're doing and what am I doing wrong? They've all matched into residency. All my friends have moved on. It's just me that's left behind. Do you have a lot of anxiety or depression about studying for this exam? Are you worried that you're going to get a low score and not become a doctor someday? Or do you even feel like, hey, listen, I don't know how to figure this stuff out. I don't know what I'm doing. I need a coach. Then this course is for you. This is why I created this course. Now let's look at how they typically teach you medical school. So here in the United States, this is typically what the curriculum looks like. They start with basic sciences, right? You have here, they're gonna teach you microbiology, biochemistry, genetics, anatomy and physiology, right? This is your basic sciences. And then you go to second year and they start teaching you the clinical medicine, which is grouped into pathology, right? They teach you different pathologies of every disease in every organ system. And then they tell you about the disease presentation, right? So here's the disease presentation. And then move on to tell you, hey, listen, this disease has the signs and symptoms that you should watch out for when you examine your patient. These are your physical exam findings. And they tell you exactly the diagnosis, which is usually what the disease is. And then we teach you pharmacology on how to manage it, right? This is wrong, right? You know the problem? A lot of students get this way of studying and they get A's on the exam. There's nothing wrong with that, right? They're like, oh, I'm a superstar. I'm a straight A student in medical school. I'm doing awesome. And then when it's time to study for boards, it's different. The USMLE and the NBME, the National Board of Medical Examiners, they have a different approach. They look at the human body as just one, not parts of GI, parts of cardio, parts of renal, a little bit of respiratory. The human body is just one piece. So when they test you, they're gonna start with giving you a clinical vignette. Right? Shocker, right? You're like, oh my God, in medical school, that's not how they taught me. Yes, I understand. Don't freak out. They're just laying the foundations. However, for the board exam, you're going to notice that they're going to give you clinical vignettes with cases. It's going to be case-based, right? Inside that case presentation, they're going to give you the pathophysiology of the disease, which they expect you to know inside the case. And then we'll give you signs and symptoms of the disease, which could be any system, all right? It could be GI, it could be renal. And then they'll describe the physical findings you're going to find on the patient. And then they want you to come up with a diagnosis, right? Which recognizing what microorganism that's causing the disease or what pathology is causing that diagnosis. We give you an idea how to make the diagnosis itself, and eventually management, which could be pharmacology, surgery. Now, this is the real world. The reason why the USMLE tests you this way is because in your future, when you become a doctor like me, I practice emergency medicine. Your patients, my patients, when they come into the emergency department or your office, they're not going to be coming in with a clinical vignette on top of their forehead, right? You're going to have to know the right answers to ask the patient, because they're not going to be able to tell you except you ask them. The only way you're going to know that is by learning this way. This is why the USMLE is different. This is why you are frustrated about the test. This is why you've memorized every fact in the book, and when you do questions, you get them wrong, because they want you to change the style and the way you think. They want you to think like a doctor. They want you to think like a clinician, because clinicians will see a patient, they will ask them questions. Those questions will trigger the different differential diagnosis that you're thinking in your mind, and then will kind of give you a constellation of the different management that you can use to approach that patient. So it's very simple. A patient comes in, they have a problem, you ask them questions about the problem, you make the diagnosis, and you treat them. This is how the board is different from your medical school. Now, would you like me to teach you the right way to learn? Now that you know this information, my goal, my number one goal, is to teach you to think like a test writer. But not just like a test writer. I want you to think like a doctor. That's how you're going to crush this USMLE exam. Now, this is what you're going to learn in this integrated course. We're going to be going through different modules. Every week, you're going to get an email and we'll let you know when to register, okay? We're going to go through cardiology, gastrointestinal systems, endocrine, renal, neurology, dermatology, hemonc, psychiatry, respiratory system, musculoskeletal, reproductive, and many more. Let's take a look at what typical students usually do, right? So if you're a medical student, you're studying for the USMLE, you pick up your first aid, right? Like the book right behind me. You said, hey, I'm gonna read microbiology today. Awesome. Now let's read microbiology together. So this is what a typical student does. They said, oh, look at there. I'm gonna read about Staphylococcus aureus, right? They give you an image right here. That's the image that the book gives you, right? And you're wondering like, oh, what's those little tiny little purple thing in clusters? Okay, let me read a little bit more. Well, they're gonna tell me just a random fact, gram-positive. Beta hemolytic, okay, what does that mean? Catalase positive, I wonder what that means either. Coagulase positive in clusters, And then, facts. Let's see what else. Protein A virulence factor binds the FC IgG, inhibiting complement activation and phagocytosis. I have no clue what that means. Somebody help me. Yes, I understand. That's the exact thing every medical student in the United States feels like. They're reading a bunch of facts and they're like, this makes no sense. Oh, let's check it out. The next line says, commonly colonizes nares, ears, axilla, and groin. Now, for the love of God, how do we go from something that inhibiting complement activation and phagocytosis and not colonizing the rest of the body? Well, okay, all right, that's cool. Let's read a little more. Causes: inflammatory disease, skin infections, organ abscess, pneumonia, often after influenza virus, endocarditis, right? Septic arthritis, and osteomyelitis. Okay, wow, that's a lot of diseases. Okay, what else? It can cause toxic-mediated disease, toxic shock syndrome, TSST1, scalded skin syndrome, exfoliating toxin. What's that? Just some random facts. Okay, it gets better. Maybe rapid onset food poisoning, enterotoxins. And then the next line, we got MRSA. What the hell is MRSA? Methicillin resistant staph aureus, right? Okay, important causes of some serious nosocomial and community-acquired infections resistance due to altered penicillin binding protein. MEC gene from Staphylococcus chromosomal cassette involving the penicillin resistance. Absolutely, I'm gonna rip my head off. I have no idea what I'm reading. Guys, I'm even gonna stop reading this stuff because it's giving me a headache. Does this look like you? Does this feel like you when you're studying for the board exam? I'll bet you, yes. Absolutely does. It's really frustrating, isn't it? And what do? You go to studentdoctor.net, or you're probably going to Quora or USMLEforums.com or .net. And what happens? People start describing how they're scoring 240s and 250s and 260s, and you're like, oh my God, how am I gonna get 240s and 260s when I'm scoring 10% or 20% in my UWorld QBank or my Smash USMLE QBank or Kaplan RX QBank? And everybody told me to do questions, right? Wrong. That's your ultimate problem right there. This is the number one reason students fail the exam. All right, now let's stop this crap and let me show you how you're supposed to learn it. I have just summarized everything we just talked about into 2 slides. Let's read it. Staphylococcus which is a bacteria, is a gram-positive bacteria in cocci, which is a small, round little ball. That's what that little ball I showed you earlier looks like. These tiny little stains, that's gram-positive because they turn purple. Now, it produces catalase. Catalase. What's catalase? Catalase catalyzes an enzyme that breaks down hydrogen peroxide. I wonder what uses hydrogen peroxide. Have we heard about the oxygen myeloperoxidase pathway in neutrophils? Oh, that's how they destroy bacteria, doesn't it? Why is that important? Because if my neutrophils, which are my PMNs, can come around and destroy staph, then I'm good. They can cause infection in my body, but if this sucker has catalase, it's gonna break down literally the same bullet that I'm trying to use to kill it. It just takes the two cases, breaks into two, it's like, what else you got? And then it has coagulase enzymes to protect itself, because coagulation, anything that has an ACE in biochemistry is what? It's an enzyme, guys. It takes coagulase to make fibrin. Now, what fibrin does? Remember, in the coagulation cascade, the ultimate goal of hemostasis is making fibrin. You take that fibrin and you protect yourself like a little nest. So we're gonna build a little house around ourselves and start having sex and making more bacteria. Ew! Yes, that's exactly what staph does. Now, see what I just did? I just explained to you why that first line is important. Do you ever gonna forget that? That's called understanding and not memorization. That's what I teach you in this course. Well, let's go a little further. Staph, it's called Staph aureus. A for aureus, so it produces protein A. Remember that. A for aureus, A for protein A. Is that easy? Come on, guys. That's really easy to remember. But why is that protein A important? Remember, we can make antibodies that binds to complement. Complement activation eventually causes neutrophils to bind to them together to go attack bacteria, to poke holes in the peptidoglycan membrane so that we can destroy this bacteria for good and get rid of these suckers. But what's going to happen is that protein A is going to prevent the FC portion of IgG antibodies and block activation of complement. If I cannot activate complement, folks, I cannot kill the bacteria. And I can't eat the bacteria and destroy it using my lysosomes. So guess what? Staph just protected itself again. That's why proteinase is important for the board exam. Now, remember they told you, if you look at the first slide, oh, it found, let's see, in the nose, in the ears, axilla, and your groin. You know you can group all this and call it just your skin, right? Yeah, it's in the skin. It's on the skin. It's everywhere. That's an easy way to memorize. That's like, does it find the ears, nose, axilla, and groin? Well, it can be found anywhere. Okay? I just summarized the first section. Now, we're going to take staph, okay? And let's do a simple problem. How are we going to teach this integrated course again? Let's take staph organism. I'm going to remember that bacteria, and we're going to call this guy Johnny, okay? Let's take Johnny right now. Here's Johnny. All right. And Johnny has a heart, and he has a feet. All right, that's Johnny's knees. This is Johnny's brain. All right, perfect. We're gonna take staph, and anywhere I plug in staph, it's gonna cause a problem. All right, follow me? Let's go. So Johnny's gonna represent you on the board and gonna tell you Johnny basically just had recent brain surgery, right? So you gotta cut through the skin, right? And when you cut through the skin, there's bacteria in the skin. Although you do a lot of prepping to prevent bacteria from getting in, but what eventually happens is the bacteria can get inside the brain. That's a risk of any surgery, all right? The skin is the largest organ in the body, and it protects us from having bacteria in our skin getting inside. So what happens is, if the patient now wakes up 2-3 days later with fever, headache, neck stiffness, something like that, or you do a CAT scan of the brain and you see air collection inside the brain, the patient has a brain abscess. Guess who's causing it? Staph aureus, baby. If I have abdominal surgery and post-operative and there's a pocket of pus inside my abdomen, it's gonna be a pelvic infection, which is a pelvic abscess. It's still staph. The same thing in the lungs. If I put a chest tube in the lung and the lung develops an infection after a couple of days, it's probably going to be staph aureus, except there's other organisms inside the lungs. But for the sake of this argument, it's gonna be staph. See how easy it is? I just took one bug and put it in the brain. Remember, it makes fibrin. With what? Coagulase. Very easy. Okay? That fibrin clot is always protecting itself so that it kind of continues to replicate. Let's go from Johnny's head and we're going to go into Johnny's skin. On Johnny's skin, staph can cause abscesses. Okay? If Johnny's in the hospital, anytime they tell you on the boards and you hear the word nosocomial, it's not picking your nose. It's basically patients that come to the hospital, and the bugs that are in the hospital are called nosocomial infections. Remember that from now and forever. So what happens is, with Johnny, if he has a fluctuant mass on his skin, he's gonna have a skin abscess. If you just come from the hospital and you describe it in the question, it's MRSA most of the time. Now, patients, if they give you a patient that's having a peeling skin, they have a fever, rash, and the skin starts like to be desquamating, right? That's called scalded skin syndrome. That's exactly the same organism, guys. It's still Johnny. Same organism, different places. How else, if I want to test you inside the lungs, they're always going to give you the case of a 65-year-old female that just had fever, rhinorrhea, sore throat, body aches or myalgias, right, for about a week. Tested positive for influenza A. Okay, that's classic symptoms of influenza. And then they come back about a week later and they say they're coughing up greenish sputum. You should think, wait a minute. That is staph pneumonia, guys. That's why it says post-influenza here. Earlier, when we were learning about it, when we're just reading first aid, haphazardly, just go with the flow. How about in the heart? They're gonna give you a case of a patient, right? IV drug abusers, they love this vein, guys. Antecubital vein, they're gonna inject it right in there, and it's gonna go right into your brachial vein. From the brachial vein, it's gonna end up in the subclavian vein under the clavicle, straight down into the superior vena cava, straight out. What's the valve that sits right in the right atrium? Well, it's tricuspid. So why are you memorizing this stuff? It's gonna end up causing staphylococcus, tricuspid, endocarditis. It's gonna eat up that valve and destroy it, and you're gonna have a new onset of a new murmur. That's it, guys. I just talked about endocarditis in just a couple of seconds. All right. How about on the musculoskeletal portion? They're gonna tell you about Johnny. All right. Johnny's gonna come in with knee pain. His knee is gonna be swollen, edematous. It's gonna be warm to touch, erythematous. It's gonna be monoarticular pain, and this patient is gonna have a septic joint. When you do an arthrocentesis, right, they may give you lab work. They're gonna tell you the ESR, erythrocyte sedimentation rate, or CRP is elevated. The WC count is gonna be 50,000 with PMNs, a lot of neutrophils in there. That is a staph septic arthritis. Now, what's behind the knee? Well, let me see. We have the synovial joint, right? And we have the bone. Guess what? Osteomyelitis. It's the same infection. Sometimes it's just going to sit hematogenously and just go from the bloodstream straight into the knee and then just in the bone. Most of the time people might step on something and then that infection on their skin traps up into the bone in their toes. Like diabetics, they never feel anything. They don't know. Although Pseudomonas is one of the most common organisms that causes diabetic foot ulcers, but in the bone, they're going to have staph aureus also kind of sitting in there. That's why it causes osteomyelitis. We're still talking about the same organism, guys. We're talking about at least 1, 2, 3, 4, 5, 6 different ways I can test you on the same concept. Well, there's more. How about in the GI? They tell you Johnny went to a restaurant and ate rice, right? And 2 to 6 hours later, come in with abdominal pain, nausea, vomiting, and have a non-bloody diarrhea. There's no blood in his stool, just watery stool. What should you be thinking? You should think it's staph aureus food poisoning. That's all it is. Very, very common. People go to restaurants all the time in America and they get sick. That's exactly what happens to them. So guess what? Why does it cause that? It's going to produce the enterotoxin this time. Entero means enteric. Oh, enteric. That's right. That's just the gut. Right? So this patient is going to be sick with a heat labile, all right? A heat labile toxin that when you cook it, it doesn't destroy completely. It goes into your gut and causes massive fluid, basically exchange, causes you to have massive watery diarrhea, okay? Gastroenteritis, same organism. Well, it gets better. This is the ultimate, guys. This is the worst of the worst. We always worry about sepsis. Sepsis kills people. This is why the board cares about this stuff. They don't want you to miss stuff that kills people. They want you to go out there to be a doctor who can catch people before they die. Because if you don't recognize this, your patients are going to die. The boards, that's why they call it high yield. High yield stuff basically means it's not for you to get a 240 on the USMLE, folks. It's for you to be able to recognize things that kill people so you catch them and save somebody's life. So let's talk about septic shock, all right? When staph gets into the bloodstream, it's gonna release a toxin called TSST1, okay? That is gonna cause toxic shock syndrome, right? Look at the word toxic, and it's a shock. Well, what happens to the body when the body's in shock? When this patient has septic shock, they're gonna have fever, vomiting, rash, hypotension, End organ failure. Like what? Renal failure, their creatinine is going to be elevated. They're going to go into shock liver with their ALT and AST in the thousands. All right. And this patient is going to have hypotension. They're going to tell you this patient's blood pressure is 60/40. You better be scared about that. They're going to tell you the patient is tachycardic. All right. They have a fever. And when you get blood cultures, it's going to have staph aureus growing inside it. It's going to say gram-positive cocci inside the bloodstream. This patient needs immediate IV antibiotics, massive fluid resuscitation. They may need vasopressors, but they're not going to test you that on step 1. But I'm telling you this stuff because IU means somebody's dying. If you miss a myocardial infarction in real life, your patients will die. You're going to get sued. You're going to go to court. And it's a big deal, folks. This is why this review matters. Not to train you to pass an exam, but to show you and make you a better doctor so you can learn what you need to know to study and recognize life-threatening injuries or diseases that will someday save somebody's life, somebody's mother, somebody's son. Okay? So what are you going to see? The reason why TSST1 toxin is brutal is because it's a toxin-mediated release and it's a super antigen. Super antigens, I think about like super bugs, right? These antigens bind to the MHC portion of the T cell receptor. It's going to cause polyclonal T cells activation and increase your LFTs, which is basically from the septic shock. But this massive T cell activation is going to cause this massive systemic inflammatory response syndrome, and this is how your patients can die. This is what HIU is all about, guys. This is what we're going to be talking about. This is how I'm going to be teaching you how to study for the board exam the right way, to think not just like a question writer, but think like real doctors. Now, you're going to get outlines, right? For example, this is cardiology. We're going to go through the top 13 super high yield concepts that you cannot afford not to know. Master them cold, all right? So I'm going to give you this during the course. And let's go over a couple of examples of how we're going to be going through it. These are case-based, so it's an integrated cases. I have integrated cases so that I can teach you what you're learning from your book so you can always remember. So we're going to go over supraventricular tachycardia. We already said we're going to go over, for this case, we're going to be going about cardiac arrhythmias. So the first one is supraventricular tachycardia. Supraventricular means above the ventricle, and we're going to be looking at atrial fibrillation, right? That's supra, above the ventricle. That's in the atrium. We're still in the atrium space, okay? Atrial flutter, AVNRT, and WPW. Now, let's take a look for example. Here we go. Case study 1. We have a 65-year-old female with a history of hypertension, coronary artery disease, presented to the emergency department with sudden onset of right-sided hemiplegia. The diagnosis of ischemic stroke was confirmed. Oh, they gave it away, right? And her pulse is irregular with a heart rate of 120. Here's your rhythm strip, guys. I want you to take a look at that rhythm strip, and even before I ask you any questions, I want you to look at that rhythm strip and tell me what you're looking at. If you can do that, you have content deficit. That's how we're going to go through this case, okay? So, the first question is, what do you think is the most likely diagnosis? Now, well, let's dissect the case itself. This way I like to do this, okay, is when you're doing questions, always highlight the key things. In this board review, I already highlighted them for you. When you're taking the real board exam, you take the highlighter and you highlight hypertension, coronary artery disease, sudden onset of right-sided hemiplegia, ischemic stroke, and irregular heart rate. And also, I will highlight heart rate of 120. Because you got to recognize abnormal vital signs, folks. So what's the most likely diagnosis? Atrial fibrillation. This is an irregular rhythm that you must know in the USMLE exam. It has no P waves absolutely at all. But what is the pathophysiology? Always ask the next question, why is this just atrial fibrillation and why does this matter? Well, we need to understand the pathophysiology of disease because ischemic heart disease is one of the causes of atrial fibrillation, and what leads to that is hypoperfusion of a bad coronary artery, decreased perfusion to the cardiac myocytes, which leads to ischemia. That causes loss of cardiac myocytes, the atrium becomes thinner and dilates. That dilation is going to cause a reentrance circuits inside the atrium. The development of atrial fibrillation, unfortunately, is going to cause to stasis of blood due to loss of atrial contraction during systole. If your heart is not contracting during systole, blood is going to stay there. When blood stays there into the left atrium, for example, that clot now can go straight down into the left ventricle, straight up into the aorta, and it goes straight up into the internal carotid artery. You go to the brain, and your patient is going to have a stroke because they're saying the patient has a sudden onset of right-sided hemiplegia. Where's the stroke in the brain? Well, it's on the left. And most likely it's a left MCA, the middle cerebral artery. They love to test that. Okay, so that's how patients with atrial fibrillation are at risk of developing stroke. Very, very important that you understand that. Now, what are the clinical findings you're going to see in the patient with atrial fibrillation? Often they don't have any symptoms, right? If they don't feel it, they don't know their heart is beating fast. But if they do, they're going to tell you they have palpitation. Doc, I feel like my heart is skipping a beat, okay? And it's beating fast. If they have one of these Fitbit or something, they might be like, oh, like I see my heart rate was like 140 today and I wasn't running, all right? Or they can come with a stroke. And that's how the board's going to present it to you. All right. So let's look at it. What are the expected EKG findings on atrial fibrillation? There's absence of P waves, which means there's no atrial depolarization. That's what P wave stands for, right? And you're going to notice irregular tachycardia, right? So you're going to see here that if you map the QRS complex here to this R wave here, right? So this is your Q, it's supposed to be Q there. And the R is supposed to be S, right? If you map the distance from here to the next one, you see they're not regular. It's irregular, right? This is short, this is longer, and this is even further along, and there's no P waves. All right, you don't see any upward P wave, which would be a depolarization there, right? So that tells you this patient have atrial fibrillation, and it's a narrow QRS complex, which is common finding in atrial fibrillation. And also, you may also see some old Q waves or left ventricular hypertrophy in patients that have atrial fibrillation. So what's the treatment? Well, if the patient has a permanent atrial fibrillation, you treat them with beta blockers, all right? You want to control the rate. You want to slow down their heart rate. If they're beating at 120, bring them down to 75 or 78 or 80s, okay? Because their heart is beating too fast. Why isn't that important? It's because when the heart beats too fast, you don't have enough time for systolic and diastolic, which means the heart is not able to relax and contract at the same time to be able to get good, adequate cardiac output. You get hypoperfusion to the patient's head, also to all the organs, so they might start feeling dizzy or lightheaded. So you want to control their rate, okay? And then if the patient also has a first documented atrial fibrillation or recurrent atrial fibrillation or paroxysmal atrial fibrillation or persistent atrial fibrillation, they may benefit from rhythm control, right? So what that basically means is that's the first time they come with atrial fibrillation. You can cardiovert this patient, okay? It's a machine in the emergency department that you can basically synchronize and you shock them out of the rhythm and put them to normal sinus rhythm. Now, the definitive treatment can be achieved with a radiofrequency catheter ablation, where you go into the heart and actually ablate off those myocytes that's misfiring in the atrium. Also, you want to treat the patient with aspirin or clopidogrel, and this is to prevent the patient from having a stroke, okay? Especially in low-risk patients. In high-risk patients, you want to start them on warfarin or start them on rivaroxaban that are used to treat high-risk patients, okay? So it's very, very important that you know how to manage atrial fibrillation, because they can test you on this on the board exam. Rate control with digoxin or beta blockers. Also, you can use calcium channel blockers also to be able to, like diazepam, that you can use also to control the patient's rate also. That's another option, okay? So now let's look at case study number 2, right? We've got a 65-year-old male, history of hypertension. Remember, everything highlighted is important. History of hypertension and coronary artery disease. They presented to the emergency department with same symptoms of sudden onset right-sided hemiplegia. The diagnosis of ischemic stroke is confirmed. Here's her pulse. Her pulse is regular, but her rate is 150. Let's look at the EKG. This is a little bit different, all right, compared to what we just did at first. What's the diagnosis in this case? I want you to look at that EKG and tell me the right answer. If you don't know, that's totally fine. That's why you're here. This is atrial flutter, right? This is different from atrial fibrillation. In atrial flutter, what you're going to notice is the presence of this sawtooth pattern P waves, right? See, but 1, 2, 3. Those are three. So what you're going to see is 3 P waves, okay? Right there. They look like sawtooth pattern, all right? Up, down, up, down, up, down. And then you get a Q wave, S wave, and then it's another sawtooth pattern, okay? This is classic atrial flutter, all right? It could be a variable atrial rate, all right, which means an AV block of 2-to-1 conduction or 3-to-1 conduction, which is suggestive of atrial flutter. So in this case, you have 3-to-1 conduction, right? 1, 2, 3, and then you have a Q and S conduction here. That's a 3-to-1 atrial flutter. If it's only 2 P waves, it's only 2-to-1, okay? So what is the pathogenesis of atrial flutter and how is it different from atrial fibrillation? Well, in atrial flutter, you can see P waves on EKG. On atrial fibrillation, you cannot see P waves on EKG, okay? So this happens in atrial flutter because there's a re-entry circuit that is formed that involves your SA node and then passes into the major pathway there, then tricuspid AV region, creating that P wave. And what is the hemodynamic compromise? More likely in atrial flutter, because when you have an AV block rate of 2-to-1 conduction, or there's no AV block, AV nodal block, the patient can become hemodynamically compromised. They can become hypotensive. That's why this is even more serious. Same case. What is the definite treatment for atrial fibrillation? You want to do a radiofrequency catheter ablation of the abnormal circuit. And what is the rate control treatment of atrial flutter? Just like atrial fibrillation, calcium channel blockers, beta blockers can be used to control their rate. Now let's look at another case here. We have a 5-year-old male that presents to the emergency department with dizziness, dyspnea, and history of pre-syncope. His pulse is irregular, and the heart rate is 120. The patient informs you that he no longer feels dizzy, and an EKG is obtained at this time, which is shown here. So I want you to look at this EKG and tell me what you think. Actually, the answer is right there on there, but we're going to talk a little about it. The most likely diagnosis is a Wolff-Parkinson-White syndrome. They love to test you about Wolff-Parkinson-White syndrome on the board exam, and what you're going to notice is the arrow is pointing on the EKG to something called a delta wave, okay? A delta wave is actually just an early depolarization of the ventricle through an accessory pathway. So this little blip right here, that's a delta wave right there. That's a delta wave. That's a little upstroke before the QRS complex. Okay, remember that for the board exam, super high yield information. Now, what are the possible locations of the accessory pathway in WPW? Well, the left atrial free wall cannot be an accessory pathway, more likely less than the posterior septal, more than the right atrial free wall or the anterior septal free wall. Now, what's the pathogenesis of WPW? Well, there's an accessory pathway known as the bundle of Kent. It bypasses the AV nodes and results in early depolarization of the ventricle. This can result in reentrant tachycardia. Now, what that means is if this is your heart, okay, and you split it into two right there, this is the SA node, and this is the AV node. Usually there's an accessory pathway that goes across, and then depolarization go down this accessory pathway. This allows the patient to get a reentrant tachycardia again through the AV node, and then goes back down, and that's how this patient have WPW. Now, let me ask you a question. Do you want to be like one of our students that just match into pediatrics? Her name is Dr. Taquila Williams. She matched into pediatrics. She used the Smash USMLE review course while she was in medical school, and now she's a success story. She scored 214 on step 1 and a 231 on USMLE step 2. Let's hear her story.
So I ended up ranking Charlotte and Alabama, UAB were 1 and 2, and then Memphis was my 3rd. So they all felt really good.
So you matched pediatrics, right?
Yes.
How many interviews did you get?
18 or 19.
I said, where did you rank your program? Like, what number did you rank your program?
Oh, this was 3.
I matched my number 3 too. What's up with that?
I know, right?
So
number 3.
Awesome. Congratulations. I'm so proud of you. All right, let me ask you a question again. Do you want to be like Carolina Gonzalez? She's a MS3 MD PhD student at the University of Miami. She passed the USMLE with 231. She sent me her board scores and the transcripts just as a proof here so you guys can see, so it can motivate you to tell you, listen, you can become the next success story on our board review course. Also, if you go on Facebook, you can see, our testimonial. Here's Ashley. She took our course. Here's what she had to say. This is the most helpful, great resource, very reliable, and awesome video lectures if you're preparing to ace the USMLE Step 1. Dr. Adesina is a very good instructor and funny. You will not get bored in studying. I assure you that. Use this and it's really a great help. Thanks to you, Smash USMLE. All right, you can check it out on our Facebook page at Smash USMLE Reviews. Now, let me ask you another question. Here's another one of our students. His name is Faisal. He took our course and he scored a 250 on step 1. And here's his score. He sent it to me after. I was so proud of him. And you can become the next success story just like Faisal. Now, he's an international medical student. He graduated in 2015, but here 3 years later, he's celebrating a top score on the board exam. Now, let me ask you another question. Do you want to be like Easy? Easy is a first-time USMLE test taker. He took our course and he passed with a super awesome score of 239. All right, he's got 240 on step 2. I want you to listen to his story.
I'm Nigerian, actually. Then I went to Ukraine to do med school, graduated, and came to the States, started the USMLE process. I just got my ECFMG certificate, so I guess that's a plus.
Nice. With that, what does that allow you to do?
Well, it allowed me to take the step 3 and apply for residency next year.
Awesome. Congratulations.
Yeah.
How did you do on step 2?
I got a 240.
Good. You went up by 1 point.
Yeah.
Oh, awesome. I think you're on track. I think you're going to get in with those numbers.
I hope so. That's the prayer. So
that's his story right there. Listen, my average scores for students that are coming through my course is between 220 and 238 with a 97% pass rate. I would like you to be part of the next success story. So you can send me an email and your score report and say, hey, Dr. Adesina, I did super well. So what are you gonna get with this online review course? You're gonna get a live online class for each subject that you register for, which is valued at $499. Also a full USMLE schedule and course outline that's worth of $50. And also an instant video replay that's only exclusive to you that you register part of the class for $199 value, and an Insider Secrets ebook that I'm gonna give you, which is worth $99 in value. Also get my free USMLE exam rituals on how to study the right way on the exam day and also take the test and get rid of your anxiety. That's worth about $49 value. I'm gonna also give you access to my exclusive USMLE study framework that's worth $199 in value. You get a total value of $1,100. Now let me ask you a question. What's scoring high on the USMLE and matching into residency worth to you? $3,000? $10,000, $25,000, or $50,000 or even more? Well, let me ask you another question. If all this package gave you was a kick in the butt to motivate you to finally put you back on track and you can pass your USMLE on your first or the next attempt, will it be worth $1,100? Okay, let me ask you another question. If this package helped you pass your USMLE, right, and you start earning, and when you become a doctor, in a few years from now, about $220,000 to $450,000 to even $500,000 in revenue, that's a lifetime earning of about $6.2 million to $13.5 million in income. Imagine what you can do with that. Instead of now passing this exam and end up working at a convenience store making $20,000 or $30,000 for the rest of your life. Will this be worth it to you? Well, let me ask you another question. How much are you willing to pay for your MD license that you worked so hard to get to this point in your career? Or do you want to have a chance to live your dream and practice in medicine and know this stuff that's going to save somebody's life someday? You can even put a value on that. Well, I'll pay $1,100 all day for that every single day because it's an investment in my education. So this is the reason why most of my students are willing to pay me this amount of money, because I give so much value to you, because I'm here to help you, and you're going to get a total super high return on your investment. Now you can see why this is a good deal even at $597 if I offer it to the general public. But because you're special, you're gonna get started now with this program, and I'm only gonna have you pay $97 just for each module that you register for. Now, here's what you need to do next. Click on the Get Started button right now to complete your checkout process, and you're gonna get an email for when your next class is gonna be ready so you can begin your journey. Remember, seats are very limited. I want you to click right now and register, because seats are limited. It's only limited to 50 students. I don't take a lot of students in my program. I only take serious students who care about getting through their boards, know what they're gonna need to know to become better doctors in the future so we can help take care of the next generation of our patients. So I want you to click right now to register so you can sign up for the program. Listen, this is exactly what you're gonna get. It's a total value of $1,100, but you're only gonna pay $97 only. This is a limited time offer for you to sign up. Now, if you have any questions, just shoot me an email to dradesina@ftplectures.com and I will reach out to you immediately so I can help you through this process. Okay, so click right now to register, make the payment, and so you can get so you can reserve your seats in the classroom, because once the class is filled, I'm gonna close the course and you're not gonna have access to it anymore. Now, every week, we will be discussing and dissecting every subject, the case modules. We shall be talking about why they're important, why they're relevant. So you're going to be checking your emails to get the next upcoming class for you to register to sign up for the program. You have to pay for each separate program every time you try to come on the program to register for. So remember, this will totally change your life. It's super added value. You're going to get to meet all the students that are also in the class, to interact with them. If you need a study buddy, you can meet some of my students that are already studying. You guys can get together and study also. You also have me, where you get to reach out to me and say, Dr. Adesina, I need help. Hey, listen, I'm part of your classroom. I'm always available to you by phone, and I'm also available to you by email. So you get one-on-one personal communication with me. You can also reach out to my team at smashusmle.com, and you can call the number and they'll be able to also help you. But if you need to reach me, I am telling you right now, I want you to register right now, because seats are limited, only to 50 students. Click right now to register. I'll see you in the class. Get ready, smart docs. Let's go.